Hello students, good day to all of you. So this is Dr. BK for you, and today I am going to discuss a very interesting topic on the thorax is the pleura. So the pleura of the lung, we will be discussing basically a short introduction of the definition of the pleura and how actually the pleura develops. Followed by that, we are going to see the various subdivisions of the pleura and then the pleural reflections. So how they reflect over the different surfaces of the walls of the thorax and how they are named according to it. Then we are going to discuss very importantly about certain spaces which are present within the pleura, and they are called as the pleural recesses. Followed by that, we are going to just touch upon the nerve supply and the blood supply of the pleura, and finally we will conclude this session with discussing about the applied anatomy. Now, so basically, introduction to the pleura. What actually is pleura? So here you are able to see the lung, and the lung is covered by a covering. It is not a single covering, but it is present as a double layered covering. Okay, so the blue color line you are able to see, which is actually surrounding the lung, and then you are able to see the red color line. So this double layered membrane is actually called as the pleura. Okay, and it is a serous membrane, which means the secretions are actually serous in nature. Okay, originally it is a large sac, and which has been reduced because the lungs have actually come and occupied, or it is not occupied, it has occupied only the space but not inside the pleural sac. The pleural sac as such, it is present like that, and what you call as the pleural cavity is actually this thin space which is present between these two layers. Okay, so this is actually the pleural cavity, and it is filled with the pleural fluid. Okay, this pleural cavity is actually filled with the pleural fluid. So that means the lung is actually covered by the two layers of the pleura. Okay, but it is not present inside the pleural cavity, because that means it should have been present in the space which we see here. Okay, so to strictly speak, that means the lung is not intrapleural, it is extrapleural in nature, but it is invested or covered by pleura on all the sides. Okay, so this membranous covering is a serous membrane, so which produces serous secretions which is mostly watery in nature. When it is somewhat sticky in nature, we call it, or thick in nature, we call it as mucus secretions. Okay, now here, from where actually this membrane is developed? As I told you, basically all the cavities of our body is derived from the coelomic cavity. Okay, they are to initially start with a space which is called as the coelomic cavity, and certain structures they invade. Now here you are able to see the lungs, slowly they are developing and they will come and occupy this space. Now you are able to see a lot of space here, but now you are able to see it is only a thin space you are seeing surrounding the lung. So originally this large empty space has been taken up by the lungs. Okay, so this is the case even for the heart, which you are able to see the pericardial cavity. Same way this is going to be the case in case of the abdomen also, that is the peritoneal cavity. You are able to understand. So they are all basically a coelomic cavity which is lined by serous membrane. So these large spaces are then reduced to a potential thin space because of the invagination of the viscera, and in this case, in case of the pleura, it is the lungs which is actually invaginating into this. So this diagram, a very simple diagram, you can understand here. Large two serous sacs you are able to see. Slowly what happens is the lung is occupying the space, and thereby this large space which you see here, now it is reduced a bit, now it is reduced a bit, and ultimately when the lung completely develops, what was initially a large serous sac has been reduced to a potential space. Okay, so the lung is actually pushing these two layers, and thereby you get two layers of the pleura. So nothing is present in between these two layers, it is only the pleural fluid which is present, because these layers, the cells lining these layers, they secrete the pleural fluid. As the lungs evaginate, the large serous sac is reduced to a thin potential space. So each lung invaginates from the posteromedial side. So this also, most of the organs, your lung, your heart, and all the organs of the peritoneal cavity also enters into the coelomic cavity from the posterior aspect. So as I told you, this large space is reduced to a very thin potential space. So because of this, originally this sac, now it has become into two layers. Okay, so one you call it as the parietal pleura, the other one which is closely investing the lung is actually called as the visceral pleura. Okay, now both the layers are actually separated by a thin film of fluid which is actually called as the pleural fluid, but at the region of the root of the lung, you are able to see both the lung are anchored in the midline to the, this is your trachea and the bronchus, which is holding the lung in its place. So it is anchored to this bronchus by the root. So these structures which hold the lung is actually called as the root structures. So at the region of root you are able to see, or the root of the lung, both the layers, they are continuous with each other. So that means this serous sac is actually a closed sac. Okay, it is not open or does not communicate outside. It is a closed sac, and both the layers, even though it is separated at one place at the root of the lung, you are able to see they are continuous. One reflects onto the other. Now, first coming to the pleura, you all know that we have two layers of pleura. One is the parietal pleura, which is more adherent to your thoracic wall, and the diaphragm. Okay, boundaries of your thoracic wall. The next one is actually the visceral pleura. So viscera means organ. So which is more closely investing the organ or closely related to the viscera is actually called as the visceral pleura. Okay. Now it invests the lungs as I told you, but at two places. One is at the root of the lung. One is at the root of the lung, it just moves medially from the lung. You are able to understand. And other one is the place which is actually called as the pulmonary ligament. So I will come to it after a few slides. What is pulmonary ligament? Now this visceral pleura cannot be stripped off like the parietal pleura from the lung. It closely invests the lung, and it is adherent to the connective tissue layer of the lung. Okay, and not only that, it also just enters into this fissures of the lung. It goes inside and also lines the fissures of the lung. So this visceral pleura is also called as the pulmonary pleura. So now you are able to see the lung, but it is labeled as visceral pleura, which means you cannot separate this pleura from the lung. Okay, whereas the parietal pleura, it is mostly close to your body wall, that is your thoracic wall and the diaphragm, and one more structure in the midline which is actually called as the mediastinum. It is going to line all these structures. Okay. So now we know the pulmonary pleura or the visceral pleura is the same and one, and it closely invests the lung, more adherent to the lung, and as I told you, it also lines the fissures of the lung, and it shows all the modalities of the lung. That means it behaves, it has all the properties of the lung, which means its nerve supply, its blood supply, all those things are as the same as the lung. Okay. So that is about the visceral pleura. Now we will pass on to the next one, which is the parietal pleura. Okay. Now we are able to see the two pleural cavities. Okay, we have two pleural cavities. The lung has been removed along with the visceral pleura. So now we are able to see the pleural cavities with the lung removed, and the parietal pleura is going to line all these structures. So it lines the inner surface of your thoracic wall. So that means it is going to line the inner surface of the ribs, costal cartilages, intercostal muscles. Okay. And these all these structures which I told now, the costal cartilages, ribs and the intercostal muscles, they all are separated from the parietal pleura by one fascia. You know that is called as the endothoracic fascia. Endothoracic fascia. Okay. So it lines your thoracic wall, that is your ribs, costal cartilages and intercostal spaces. Then it also lines the upper surface of the diaphragm. That part of the parietal pleura which lines the inner surface of your ribs or the thoracic wall is actually called as the costal pleura. You know, anything referring to the costa means ribs. So it lines your inner surface of your ribs, intercostal spaces, costal cartilage, and that is called as the costal pleura. The one which lines the upper surface, reflects onto the upper surface of the diaphragm, is actually called as the diaphragmatic pleura. Okay, it's called as the diaphragmatic pleura. The next, what you see here, the pleura which covers the apex of the lung. Okay, beyond the thoracic cavity, it is just going to your root of the neck, because the lung is projecting above the thoracic cavity into the root of the lung. This part of the lung which is called the apex of the lung. Same way the pleura also which is covering that part of the lung is actually called as the cervical pleura. Cervical means neck. So because it is covering the root of the lung which is present in the neck region, so that is why it is a root, not root of the lung, apex of the lung which is projecting into the neck region. So naturally the pleura covering that is also called as the cervical pleura. Okay, this part of the pleura is actually called as the cervical pleura. Then you are able to see both the lungs and both the pleural cavities are separated by some structures in the midline. So what structure we all know that is the heart with its covering is actually called as the pericardium. Okay. Then there are other more structures. Now this structure is present in the midline and it is present between the two lungs, and it forms a septum, a midline septum for these lungs. That is why they are actually called as mediastinum. So the structures in the mediastinum will be not only the heart but also some other structures. The great vessels which are emerging and also which are coming down and opening into the heart. Your trachea, esophagus, thoracic duct. So they all form again these structures in the mediastinum. Okay. So the parietal pleura lines this mediastinum and thereby separates this surface of the lung from the mediastinal structures. So they are actually called as the mediastinal pleura. So we have seen costal pleura, we have seen cervical pleura, we have seen diaphragmatic pleura, and we have also seen what is mediastinal pleura, which actually lines the mediastinum. Okay, so that is the mediastinal pleura which is shown with an arrow. So now if you look at all these subdivisions, they are all which are nothing but part of the parietal pleura. Parietal pleura. These parietal pleura shows all modalities of a body wall. So it is supplied by the blood vessels and nerves of the body wall, and it also have pain sensations that of the body wall. Okay, pain sensations. Now we will see each and one of the subdivisions of these parietal pleura one by one. So that is the costal pleura, cervical pleura, diaphragmatic pleura, and the mediastinal pleura. So the costal pleura lines, you are able to see this is the costal pleura which is lying in the interior of your ribs. Naturally, it is going to line the inner part of your intercostal spaces. Then it also lines the sides of the vertebra. It also lines the sides. So you are able to see from the ribs, it is reflecting onto the sides of vertebra, and the place where this costal pleura is going to line the side of the vertebra, that is called as the costovertebral line of reflection. So this line you see here, it is actually called as the costovertebral line of reflection. Same way, if you look from the sternum, behind the sternum, what happens is, then it will actually reflect to cover the structures in the mediastinum. Okay, so behind the sternum, the costal pleural becomes the mediastinal pleura. Here also what happens is, the costal pleura from the sides of the vertebral body, it also becomes the mediastinal pleura. So I told you the place where posteriorly the costal pleura continues as the mediastinal pleura is actually called as the costovertebral line of reflection. Same way, here behind the sternum where the costal pleura is going to become continuous as the mediastinal pleura is actually called as the costomediastinal line of pleural reflection. Costomediastinal line of pleural reflection. This costovertebral line of reflection will be 2.5 centimeters lateral to the body of the thoracic vertebra. 2.5 centimeters lateral to the body of thoracic vertebra and extends from the 7th cervical spine. 7th cervical spine to the 12th thoracic spine. From C7 to T12 you can see the posterior border of the cervical pleura, they are continuing as the mediastinal pleura along the sides of the vertebra, and it is called as the costovertebral line of reflection. Okay. Now this anterior border of the pleura, where the costal pleura is going to become the mediastinal pleura, that is actually separate, different from the both sides, right side and the left side. So that I will come to it after a short while. Okay. Now if you look at the costal pleura, below it is lining or reflecting onto the diaphragm, and this is actually called as your diaphragmatic pleura. So this line you are able to see here, where the costal pleura is becoming continuing as the diaphragmatic pleura, that is actually called as the costodiaphragmatic line of pleural reflection. This is actually your costodiaphragmatic line. This is your costovertebral line, and here what you see, this is the costomediastinal line of pleural reflection. Okay. So behind it is continuous with the mediastinal pleura, the costovertebral line of pleural reflection, which I have just explained a short while ago. Then if you again trace this costal pleura, above what happens, it is continuous with the cervical pleura. So you are able to see the cervical pleura is extending beyond the first rib into the neck. So and it is continuous as the cervical pleura. Okay. So we have seen about the how the costal pleura reflects as the diaphragmatic pleura, cervical pleura, mediastinal pleura. Now if you look at the pleura, this is the diaphragm, and the pleura which is lining on the upper surface of the diaphragm is actually called as the diaphragmatic pleura. Okay. So this is the diaphragmatic pleura, and as you come laterally, if you trace this diaphragmatic pleura laterally, it is going to continue as the costal pleura. Same way as you trace medially, it is going to get continuous with the mediastinal pleura. So the diaphragmatic pleura laterally it is continuous with the costal pleura, medially it is continuous with the mediastinal pleura. Okay. The next, this part of the pleura which you are seeing is the cervical pleura. So this red line, what you see here is the inlet of thorax. You are able to see that is actually the thoracic inlet. Above the inlet or beyond the inlet, you are able to see this cervical pleura. So this, if you look at the tip of the cervical pleura, it extends 2.5 centimeters above the medial end of clavicle. Clavicle will be articulating here. 2.5 centimeters above the clavicle is the summit of the cervical pleura. Okay, and 3 to 4 centimeters above the first rib. But again, here listen carefully. It is 3 to 4 centimeters above the only the anterior part of the first rib, but not above the posterior part or the neck or the tubercle of the first rib. That means it does not extend beyond the neck of the first rib. So the neck part, head part and tubercle part is at a higher level as compared to the anterior part. See how obliquely it is placed. So from here it is 3 to 4 centimeters, but from here no, absolutely it is 0 centimeters. It does not extend beyond this part of the rib. So if you trace the cervical pleura, it is nothing but the upward continuation of the costal pleura. Then after covering or summit of the lung, then medially it is continuous with the mediastinal pleura. Okay, from here if you get down, come down, proceed downwards medially, it is continuous medially as the mediastinal pleura. Okay, so here you are able to see that this costal pleura is actually extending 2.5 centimeters above the medial end of the clavicle, 3 to 4 centimeters above the first rib, but it does not extend beyond this part. You are able to see the neck of the first rib. Okay, and I told you this is actually the costo-mediastinal line of reflection, where the costal pleura is getting continuous, becoming continuous with the mediastinal pleura. Okay, now if you look here, this reflection behind the sternum at the level of sternal angle where the second rib articulates. Then from the right side and left side it is the same up to the second rib. Then again from second to fourth rib it is the same. So between the second to fourth rib, it is at this place you are able to see the both pleura are in close contact, close approximation with each other. They are not separated by the mediastinal structures. Both the pleural cavities were close contact. So inside or deep to this pleura, you can see the anterior border of the lung. They are also in close contact with each other. This close contact between two sides of the pleura occurs only at two places. One is between the second to fourth rib anteriorly or behind the sternum, and posteriorly at the level of T8 and T9 thoracic vertebra. It is that place where what happens is the esophagus will actually pass anteriorly in front of the descending thoracic aorta. Okay, the esophagus suddenly will move anteriorly, and thereby what happens, both the pleura are actually in close approximation with each other. There also it forms a fold. There is a fold which is called as the mesoesophagus. Mesoesophagus. Okay. Now I told you anteriorly between the second and fourth rib it is in close approximation. Now from the fourth rib onwards, the pleural reflection differs for the right side and left side. Let us see for the right side. So right side what happens? There is no change. It again comes up to the sixth rib. This is actually the xiphisternal joint. Then seventh rib, this is called as the costoxiphoid angle. This is actually called as the costoxiphoid angle. Then from there what happens? It reflects like this. from the costoxiphoid angles, the lower border, you can see at the mid-clavicular line, it is at the 6th rib, sorry, 8th rib, not 6th rib, only the lung will be at 6th rib, 8th rib. Mid-axillary line, it will be at the 10th rib, and posteriorly scapular line, it will be at the 12th rib. So 8, 10 and 12th rib. Mid-clavicular line 8th rib, 10th rib mid-axillary line, 12th rib scapular line. Left side, 2nd to 4th close approximation, from the 4th to 6th, it deviates laterally, okay, because of the heart is present here, and that the lung is also deficient, forming a groove for the notch, which is actually called as the cardiac notch. It is notched. So the pleura also deviates from 4th to 6th laterally. So it does not cross the costoxiphoid angle. This angle between the rib, last rib, 7th rib and the xiphoid process is actually called as the costoxiphoid angle. There it does not cross. Okay, it directly passes 8th rib mid-clavicular, 10th rib mid-axillary line and 12th rib. The lower border of pleura is the same. Okay, only thing between the 4th to 6th rib, there is a deviation to the left side or more laterally for the left pleural reflection, that is the costo-mediastinal reflection. Okay. Now coming back to the cervical pleura, I told you it extends from the inner border of the first rib to the apex, summit or the highest point of the lung, and then continues as the mediastinal pleura medially. Okay. So these all I have already told you, 3-4 centimeters above the first costal artery, 2.5 centimeters above the clavicle, but does not extend beyond the neck of the first rib. Okay. Now you are able to see. Now what is hidden from your view is the apex of the lung. You cannot see it because there are so many other structures which are actually present there. They form the structures of the root of the neck. So naturally, one of these structures might compress the lung, okay, when they bulge out or due to any constriction of these muscles. When this muscle is going to constrict, or if the vein is going to get distant, or these pulsations of the artery might affect. So because of that, the apex of the lung is actually protected by another extra membrane, which is actually called as the suprapleural membrane. Why it is called as suprapleural? Because it is above the pleura. So it is mostly made up of fascia, and some amount of muscle fibers is also present, which is called as the suprapleural membrane. The muscular part is again derived from a muscle which is called as the scalenus minimus muscle, and the fascia is innermost fascia lining the thoracic wall, that is the endothoracic fascia. So these two actually contribute for the formation of this suprapleural membrane. It is attached to the C7, transverse process of C7, and then fans out or expands to get attached to the inner border of the first rib. So this suprapleural membrane separates your lung and the pleura with all the above other structures. So these structures are all present outside the suprapleural membrane, your great vessels, that is your arteries or veins or your nerves. So medially the suprapleural membrane will again be continuous with the fascia, which is actually called as the pretracheal fascia, which is again a modification of your deep cervical fascia. Modification of the deep cervical fascia, pretracheal fascia. It will be continuous with the fascia in front of the trachea, which is called as the pretracheal fascia. Okay. Now why actually you need this extra protection is to protect the pleura and the lung from the structures of the root of the neck. Just now I told you, because some of these structures might compress the lung, naturally to avoid that this suprapleural membrane is present. Okay. Now we have seen about the diaphragmatic pleura, we have seen about the cervical pleura, then we have also seen discussed about the costal pleura. Now coming to the mediastinal pleura. Okay. So this mediastinal pleura is the lateral boundary for the structures in the midline. So this midline, if you go laterally this side, it is lined by mediastinal pleura. If you go this side, it is lined by mediastinal pleura. So that is why the mediastinal pleura forms these red dotted lines. Mediastinal pleura forms the lateral boundary for the structures in the mediastinum. Now this mediastinal pleura has to be discussed under three regions. You know, this is the lung root, above the lung root, at the region of lung root, and below the lung root. Okay, so above the lung root, below the lung root, and at the region of lung root, how actually this mediastinal pleura is disposed. So above the lung root, if you look at the mediastinal pleura, nothing, it forms a continuous sheet from the costo-mediastinal reflection to the costo-vertebral line of reflection. It forms a continuous sheet lining the mediastinum. Okay, then at the region of lung root, the mediastinal pleura runs laterally. The mediastinal pleura, what happens is it runs laterally to be continuous with the pulmonary or the visceral pleura. It forms a tubular sheath enclosing the lung root structures, that is your bronchus, pulmonary artery, pulmonary vein, and all those things. You are able to understand? So that is actually forming a tubular structure, thereby it is passing laterally to be continuous with the pulmonary pleura. Look, below the lung root, okay, below the lung root, what happens is it forms a double layered fold. It forms a double layered fold that is actually called as the pulmonary ligament. So below the ligament, it forms, below the lung root, it forms a bilaminar or double layered fold, which is actually called as the pulmonary ligament. The pulmonary ligament actually extends from the side of the esophagus to the lung. Okay, from the side of the esophagus to the corresponding lung, it extends. Now above, what happens? Below it is a blind fold, these two layers. Above, what happens? It is continuous with the mediastinal pleura, which is enclosing the lung root. So this is the pleura which is enclosing the lung root, where it is going to be continuous with the visceral pleura or the pulmonary pleura. Below, it forms a blind bilaminar fold. Now, there is no important structures present in this fold, some loose areolar tissue, and occasionally you can see accessory bronchial artery. So an extra bronchial artery, if at all present, then naturally what happens is it will be present in this pulmonary ligament. Apart from that, it serves as a reserve space for this pulmonary vein to dilate. So if at all this vein dilates, then naturally what happens is it accommodates this vein. This is the inferior pulmonary vein. Each lung has two veins, two inferior pulmonary veins and one pulmonary artery, right and left pulmonary artery, but right and left pair of inferior, right and left pair of pulmonary veins. One superior pulmonary vein which you are seeing here, another one is the inferior pulmonary vein. And I need not tell you that pulmonary veins carry oxygenated blood. So the ligament serves as a dead space for the distension of the inferior or the lower pulmonary vein. Okay. So far we have discussed about the pleura and the pleural different types. What is the visceral pleura and the various subdivisions of the parietal pleura. So costal pleura, mediastinal pleura, cervical pleura, diaphragmatic pleura, and then we have also discussed about the pulmonary ligament and the suprapleural membrane, which gives an extra protection to the cervical pleura. Now we will come to pleural recesses. So they are potential space, you are able to see they are potential space which permit or reserve for the lung during full inspiration. During normal breathing, what happens is the lung does not accommodate in this space. It is not accommodated in this space, or lung does not come into this space. But when you full inspire, forced, when you do full inspiration, then naturally what happens is The lung gets filled in these spaces and they are actually called as the pleural recesses. Two recesses you have. One is the costodiaphragmatic recess, very important of the two, the costodiaphragmatic recess, and other one is the costomediastinal recess. One is the costodiaphragmatic recess and other one is the costomediastinal recess. So the costodiaphragmatic recess is cleft-like, or you can tell it is semilunar in shape, the space present between the lower border of the lung and the lower border of the pleura. Now, here you are able to see this is the diaphragmatic pleura and this is your cervical pleura. So, this mediastinal and cervical pleura are also separated by this costodiaphragmatic recess. Okay, they are also not in close approximation. The diaphragmatic and the costal pleura, this is the line of reflection, but between these two layers you see they are separated because of the space which is actually the costodiaphragmatic recess. So you are able to see this is actually the costodiaphragmatic recess, and here this is the diaphragmatic pleura and that is the costal pleura. Between the lower border of the lung and the lower border of the pleura there is a space which is semilunar in shape, mostly in a side view. In a profile view you can actually very much appreciate. Same way, between the anterior border of the lung and the pleura also you have the costomediastinal line of reflection, where you have the costomediastinal recess, okay, where the costal pleura is actually reflecting as the mediastinal pleura. So lower border of pleura, as I told you, 10th rib in the mid-axillary, 8th rib in the mid-clavicular line, 8th rib in the mid-clavicular line, 10th rib in the mid-axillary line, in the scapular line up to the 12th rib. Okay, 8th, 10th and 12th rib at the mid-clavicular, mid-axillary and the scapular. So this is the scapular line. So where up to the 12th rib, the lower border of the pleura. Okay. So it is widest when you see it in the mid-axillary line. Yes. So here a lateral view along the mid-axillary line, you can see it is very wide, the costomediastinal recess. So as I told you, it expands, allows expansion of the lung during full inspiration. This space is used up, and this is the natural reason for which it is present, but clinically this is the most dependent part of the pleura. That means in case of any fluid accumulation in the pleural cavity, pleural effusion, in case of pleural effusion, what happens is this space actually is the first part to get filled up in pleural effusion. So that is why what happens is, and due to the gravity when you sit or stand, it is in this place what happens, the fluid comes to come and collect here. That is why it is called as the most dependent part of the pleural cavity. Okay, so fluid collection tends to appear here first. Only when this is filled up, this space is actually filled up, then naturally what happens is the accumulation starts to get spread to the other spaces. Now this recess inferiorly on the right side will be related to the liver, especially the caudate lobe of liver and right kidney, left side to the fundus of stomach and the spleen and the left kidney. So right side caudate lobe of liver and the right kidney, left side fundus of stomach, spleen and the left kidney. So this side it is going to be the fundus of stomach, kidney and the spleen more laterally. This side liver and the right kidney. So just a demonstration to show you the costomediastinal recess, space between your costal pleura and mediastinal pleura along the anterior border of the lung, and this is your costodiaphragmatic recess between the costal pleura and the diaphragmatic pleura. Okay. So on each side, on the midline, what you see is the costodiaphragmatic recess present between the costal and the mediastinal pleura. As I told you, the anterior border of the lung fails to occupy this recess during normal breathing. So you are able to see the anterior border of lung which has been reflected for you. So it is more wider on the left side. It is more wider on the left side. Here you are able to see more wider on the left side because of the presence of the cardiac notch, and the lung deviates from the 4th to the 6th rib. So that is why it is more wider on the left side due to the presence of the cardiac notch. So we have seen about the two recesses, which is very, very important. One is the costo-diaphragmatic recess, the first one which we have discussed, and the second one is the costo-mediastinal reflex. Now coming to the blood supply of the pleura. So parietal pleura mainly supplied by intercostal arteries, which supplies your thoracic wall, anterior and posterior intercostal. Then internal thoracic, and musculophrenic is again a branch of internal thoracic artery. This is for the parietal pleura. Visceral pleura is again supplied by the vessels supplying the lung, the bronchial vessels, bronchial arteries, bronchial veins, nerve supply. With respect to the parietal pleura, the costal pleura and the outer parts of the diaphragmatic pleura. The costal and the outer part of the diaphragmatic pleura are supplied by intercostal nerves. Okay. Whereas the mediastinal pleura and the medial part near to the pericardium, the medial part, central tendon of diaphragm, the medial part of diaphragmatic and the mediastinal pleura is actually supplied by the phrenic nerve. Okay, so costal and lateral part of diaphragmatic by intercostal nerves, mediastinal and medial part of diaphragmatic pleura is by the phrenic nerve which supplies the diaphragm. Lymphatics, parietal pleura and intercostal nodes, diaphragmatic and posterior mediastinal nodes. This is going to tracheobronchial lymph nodes. Okay, so this is mainly pertaining to the lung, and this is to the thoracic wall. So parietal pleura develops from somatopleuric intraembryonic mesoderm. So your mesoderm divides into three parts. One on either side of the vertebra is called as the paraxial. Then you have another condensation which is called as the intermediate. Then you have the lateral plate. This lateral plate will divide into two, somatopleuric and splanchno-pleuric. So during the lateral folding of the embryo, the splanchno-pleuric mesoderm will come and line your gut tube, and thereby it is going to form your smooth muscles around your GIT and of course the other structures. Same way, the somatopleuric is going to form your body wall muscles, your intercostal muscles, which we have seen. Same way, the abdomen, which is going to form the obliques muscles, external oblique, internal oblique muscles of the anterior abdominal wall. In the same way, parietal pleura develops from somatopleuric, visceral pleura develops from the splanchno-pleuric mesoderm. Okay. What is dry pleurisy? So inflammation of the pleura is simply called as pleurisy or pleuritis. In dry pleurisy, you get a frictional rub. So no pleural fluid is secreted. Deficiency due to inflammation, the cells might lose its secreting capacity. Then naturally what happens is the pleura might form a friction during your breathing movements. You get a frictional rub and pain in the place where this friction has occurred, and cough can occur. Now based on where actually, if it is going to be along the lateral peripheral parts, then naturally the pain is referred to the abdomen and neck because of the intercostal nerves. It is going to be mediastinal pleura and medial part of the diaphragmatic pleura. It is going to be the nerve supplies by phrenic nerve. Then naturally pain will be referred to the shoulder tip, referred pain, tip of the shoulder. Why? Because phrenic nerve is C3, C4, C5. Tip of the shoulder is again supplied by supraclavicular nerve, which is has again got the root value of C3, C4, C5. So these pain sensations may travel and actually present over the shoulder tip. If the phrenic nerve is irritated because of the inflammation of the mediastinal pleura or the medial part of diaphragmatic pleura. Lateral part, abdomen, because intercostal nerves, lower 5 intercostal nerves, they supply the anterior abdominal wall. Now pleural effusion, collection of fluid, that is due to pleurisy, again inflammation, any trauma to the lung, any growth, neoplasm, or in congestive heart failure, what happens is this, there might be collection of pleural fluid. So it might be collection of blood, collection of lymph, Okay, collection of blood or collection of lymph. Collection of blood is actually called as the chylothorax. Collection of blood is actually called as hemothorax, and collection of lymph is actually called as chylothorax. Okay, what is pneumothorax? If the pleural cavity, pleural sac is punctured, air in the pleura is actually called as the pneumothorax. Now, here what happens is the lung will get collapsed because the negative intrathoracic pressure falls. It is not maintained. The negative intrapleural pressure is actually minus 10 mmHg mercury. It is measured in minus 10 mm mercury. So that if that is not maintained, then what happens is the lung will get collapse due to the surface tension is not maintained. That may be due to rupture of the pulmonary bulla. Any pulmonary bulla might get ruptured. That is one reason. Or sometimes if the anesthetist, if he wants accidentally ruptures the pleura when he wants to inject something on stellate ganglion, sympathetic ganglion, or a surgeon's knife during nephrectomy, posterior approach to the kidney, the lower level of pleura is not kept in mind, he might actually incise the pleura, nicking of the pleural cavity. Okay, because of that, you see two types of pneumothorax. The first one is sucking type. Okay, so during inspiration, air is sucked in, it enters the pleural cavity, and then during expiration. So during inspiration, what happens is the mediastinum is shifted to the normal side. During expiration, the mediastinum is shifted to the abnormal side where the pneumothorax has occurred, and that is actually called as the mediastinal flutter. Okay, it is actually called as the mediastinal flutter. Mediastinum is shifted towards the normal side. Okay. The next type is actually called as the tension pneumothorax. In the tension pneumothorax, the pleura, the incised pleura acts like a valve. So when you inspire, the air gets sucked in, but when you expire, because it is acting like a valve, it won't allow the air outside. So every time you breathe, air is getting sucked in and enormous pressure is being developed, and naturally what happens is you might go for suffocation. Okay, you won't be able to breathe, you might go for suffocation, which is a medical emergency. So immediately you should insert a tube and try that air which is built in has to be brought out. The lung will be severely displaced. Displacement of the lung takes place, it has been reduced, especially in case of this tension pneumothorax. Okay, then other type of is hydrothorax, collection of fluid. Hemothorax, I told you. Blood. Chylothorax is collection of lymph. Now, any pleural effusion, what happens is the costodiaphragmatic recess will get obliterated. So you won't be able to see costodiaphragmatic recess. In case of pleural effusion, draining of the pleura is done by thoracocentesis. So first you insert a needle, see the structure spacing it, skin, superficial fascia, deep fascia, then external intercostal, interintercostal, innermost intercostal, then followed by the internal thoracic fascia, okay, then parietal pleura. Okay, so this is B, is the correct site where it has to be done. Above you go, below you go. What happens is usually it is done between the 8th intercostal space, not below the 9th intercostal space. If you go below 9th intercostal space, you are going to puncture the liver on the right side or spleen on the left side. Here above, if you go below this or above the 7th intercostal space, naturally you might puncture the lung. So along the mid-axillary or posterior to the mid-axillary line, between the 8th or 9th intercostal space is the ideal space to do the thoracocentesis. The patient is asked to sit upright so that all the fluid tends to collect here in the costodiaphragmatic recess. and then what happens is it can be drained 2 to 3 centimeters below the rib level. It is introduced, not below the 9th intercostal space, as I told you. So here you are able to see the pneumothorax, the lung has been reduced. That white line, you are able to see this pleural white line. So the pleura has been inflated, okay, but there is no fluid, only air, so that is why it is appearing black. But you are able to see the lung has collapsed, it has been pushed laterally. Here you are able to see pleural effusion, costodiaphragmatic recess, large space, and it is also opaque due to the collection of some fluid material. This is lateral or profile view. Here you are able to see again pleural effusion in the anterior view. Okay. So today we have discussed about the pleura, the pleural recesses, the clinical importance of the pleural recesses, and different types of the pleuritis and pleural effusion. So thank you very much for your patient listening. We will meet again in one more lecture on thorax.